So we move now to the third panel, the third panel entitled Let's Get Personal. I think I promised one of the panels in our preparatory call that this would be Oprah-like, but I don't think we'll get personal Oprah-like, but we really do want to come back to the individual and personalized medicine. I have to say that our last panel went down the path of first kind of being ambiguous between personalized medicine and genetic medicine or genomic medicine, and finally I think ended up pretty squarely talking about the future of genomic medicine. And so I'd like to pull us back from that particular perspective and think about personalized medicine more broadly, and coming back to the comments that were made during the first panel, thinking about, of course, the genetic profile and gene expression, but also environment and behavior and other factors that affect the individual's medical care that they receive and of course, their response to that care. So we've got a wonderful panel here to talk about this. Closest to me is Amalia Issa. Amalia is the Director of Programs in Personalized Medicine, so right on target, at the Abramson Center for the Future of Health. This is a joint venture between Methodist Hospital Research Institute in Houston and the University of Houston. Next to Amalia is Michelle Puryear. Michelle is representing the American Academy of Pediatrics, and she's on the committee on genetics at the Academy. Next to Michelle is Pilar Osorio. Pilar is an associate professor of law and medical ethics at the University of Wisconsin, but at least this year is in a much more congenial climate as a visiting professor at Boalt Hall, the School of Law at the University of California at Berkeley. And so welcome back to cold climes, Pilar. Next to Pilar is Dan Perry. Dan is the executive director of the Alliance for Aging Research. And so panel, just as we have with the previous panels, let me ask you to give a more detailed introduction of yourself, a little bit more about where you sit and where you stand. Amalia, let me start with you.
Okay, thank you. Well, I'm an associate professor at the University of Houston and the director of the program in personalized medicine and targeted therapeutics. Just to give you a little bit of a background in terms of where I stand or sit, my PhD is in neuropharmacology from McGill University in Montreal, Canada. And I also went to public health school at UCLA and have completed fellowships in medical ethics and health policy at Harvard Medical School. So I've kind of combined all of those together in the work that I currently do. My primary interests focus on translation of personalized medicine. And I define translation as taking place from bench to bedside to community. So that's a broader definition than what you normally hear when people talk about the translation of basic science. And so it takes us full circle then and takes us into consideration of societal impact. And let me share with you very briefly what I always tell my graduate students in the program, and that is that the fundamental two-part question that underlies our research, and it's very relevant for our discussion here today, is this: what will it take for personalized medicine to become integrated into clinical practice and healthcare? And what will that look like for the patient and for society? And I'd like to suggest to you this morning that there are certain universal issues that we need to address if the personalization of healthcare, and again using this broader definition of personalized medicine and healthcare, is going to happen effectively. And I'd like to put forth 5 points for this discussion. One is the need for setting priorities towards the more efficient and more effective translation from basic science to clinical application. So to give just one example among many numerous questions, how should we design better and more economical point-of-care diagnostic tests? Or another question is, how should we change the paradigm, the current paradigm of drug development research, particularly with respect to clinical trials? Because right now, clinical trials, the way they are run, aren't really adequate for the development of therapeutics that are going to be more targeted and towards more the more personalization of medicine, if you will. The second point is building research capacity and the clinical infrastructure. So that includes electronic health records, some of which you've heard about in the previous panels, as well as some other issues that we can discuss in more detail later on. Thirdly, resolving certain key legal and ethical concerns. And here I think we need to ask ourselves, what are the fundamental showstoppers when we think about questions related to legislation or ethics? Fourth, I believe we need to target research and healthcare applications to resource-poor areas. So we should really be actively not just worrying about healthcare disparities and whether this adds to healthcare disparities, but proactively moving forward in a way that tries to alleviate healthcare disparities. And finally, educating the public and healthcare providers. And we need to research really to inform policy in all of these areas. So for example, in order to implement appropriate educational interventions, whether that's targeted at various populations in a public sphere, or whether it's targeted at healthcare providers, we first have to understand what are some of the barriers and challenges that people have in terms of the adoption and acceptance of personalized medicine, and particularly pharmacogenomics. That might be a problem in terms of furthering educational interventions. And there's been really very little research aimed at understanding how patients, who really are the consumers of healthcare interventions, how they will accept or adopt these kinds of pharmacogenomic applications. That's actually a question that my group and I are working on in our research. I can speak a little bit
Let
more
me ask
to
you
that
to
now.
hold off,
I'll
and
do it, or
we'll
we
come
can talk
back to
more.
that.
Yeah.
Great, thanks. Michelle?
Hi, I'm Michelle Courier. I'm a pediatrician, and I have some qualifiers before I begin. First, my opinion does not represent the opinion of the Secretary of Health and Human Services, federal government. Secondly, I'm here representing the American Academy of Pediatrics, and that being said, I need to also qualify that the opinions here are my opinions and do not represent the opinions of the American Academy of Pediatrics. The Academy is very important, though, to this process of both personalizing medicine and incorporating genetics into personalized medicine. They represent over 50,000 pediatricians, and I think primary care, healthcare professionals, pediatricians, as well as internists and family physicians are going to be essential to the research that's needed. And I haven't heard anyone speak to the role of primary healthcare in this process. When I was asked to do this, I actually went out to 20 of my primary care pediatrician friends and asked them about what it is they thought of the 4 questions that we were asked to address. So my statement is a compilation of their answers. Many of them had to look up what personalized medicine was, first of all.
Very important indicator right there.
But once they did, they all agreed from a scientific standpoint it was very important to incorporate genetics, genomics into personalized medicine. They really all saw the value of being able to personalize one's approach to determining therapies, treatments, diagnoses, and certainly saw it as shortening their time in figuring out a diagnosis, and also would address the issue of decreasing resources that society might have to invest. But that being said, they had 4 important things that they wanted to emphasize. First, the Academy and the majority of pediatricians advocate for a universal and ensured financial access to quality health care for all newborns, infants, children, adolescents, young adults, and pregnant women. And although the Academy is advocating for a selective population, I think universal access and ensured financial access are essential for this process to go forward. I think that no one is going to participate in the kind of research that's really necessary to personalize medicine to the degree that we're talking about unless they have a part to play in it and unless there's some incentive for the ordinary person to participate. And I think universal access offers that incentive. If you, along with that, ensure that there'll be no discrimination. I don't think there, as we go forward, there'll be any real sense of protection of privacy. I don't think that's going to happen. And so I think people have to be willing to participate fully in this, knowing that there will not be privacy. But if they have universal access and and assurances of no discrimination, I think you can go forward in a more positive way. Second, the delivery of personalized medicine has always been important to pediatricians and probably to all primary care physicians, and I think we shouldn't lose sight of that. I think the majority of primary care physicians think that medicine is already very personal. And I think as you go forward with genetics, incorporating genetics, you need to remember that it has always been a part of medicine and needs to remain a part of medicine. And the personalized medicine, a personal part of medicine that I think the majority of healthcare professionals speak to is things such as the art of medicine, of laying on of hands, and in the case of pediatrics, sitting in a room with a distraught parent or comforting a child. I think those are aspects of personalized medicine that we can't lose sight of and we need to maintain. Third, we need to be concerned about the possibility of disparities in access to personalized medicine, just as there are disparities already in all other aspects of medicine. Everyone has spoken to this so far. But a concern I have about most visions of personalized medicine is their focus solely on the contribution of genetic variation to health outcomes, generally to the exclusion of everything else, such as economics, ethnicity, our environment, both our macro and micro environments, culture, poverty. And finally, I don't think anyone's addressed this yet, advances in genetics or genomics and personalized medicine have already overwhelmed many primary care physicians. And until we adequately educate healthcare professionals, I don't think we'll have the kind of informed consumers so that they can participate in personalized medicine to the degree that we expect.
Thanks. Pilar?
So I'm Pilar Osorio. I started out my professional life as a molecular biologist, which probably explains why now as a legal scholar I mostly work on issues pertaining to research governance, research ethics. And we've heard a little bit today about how we need interoperability with respect to data, databases, phenotypes, and how do we describe phenotypes and so forth. But one of the things I would like to emphasize is that we also need some interoperability with respect to passing information across legal jurisdictions and with respect to designing consent forms that can be used by people in other jurisdictions than the place where samples were collected. A lot of my work, I spend a fair amount of time as an advisor to NIH on various projects having to do with large-scale genetics, including the HapMap project, and more recently, some projects having to do with either whole genome genotyping of existing cohorts, of people in existing cohort studies, or very large-scale DNA sequencing. And as part of these projects, we have reviewed hundreds and hundreds, probably thousands, of consent forms that were used to collect material in different places around the world. For instance, we've had people submit samples from the British, the UK Biobank, but it turned out that for a number of projects, we couldn't use those samples because they were very explicitly collected with consent forms that said that no research that was done on people's samples would ever be commercialized or used by a commercial entity. And so, to the extent that UK Biobank samples were collected with consent forms like that, and there are public-private partnerships for a lot of these big genome projects, or whole genome sequencing or genotyping projects in the United States, we're not going to be able to use samples collected with those kinds of consent forms. So I do think that there is, in addition to the scientific technical set of issues, there is another set of legal and ethical issues where we really need to be working on an international set of standards that will, where we can collect samples in a way that honors everybody's, sort of every culture's desires for respect, privacy, whatever, and we can still trade samples and data and so forth. So that would be one of my points. A second thing is that I spend a lot of time looking at issues of race and justice and research. And Dr. Kittles asked a question earlier today about, and it brought up a little bit of discussion about race-targeted medicine. And when I see how personalized medicine is being interpreted in the press, how it's being sold, if you will, to the public, whether it's with BiDil or just in general, this notion that race-targeted medicine equals personalized medicine is definitely floating around out there in the world. And I am with the people who think that it's a really bad idea for lots of reasons. I think it can lead to worse health care, not better health care in many instances. And it can lead to lots of confusion, particularly when you put race targeted with genetics. Anything that has race and genetics sort of linked together in people's minds raises a lot of stereotypes, a lot of specter of eugenics, a lot of other beliefs about race that might not be explicit but are often implicit in people's concerns and conceptions about race. And when you see, I don't know if anybody has seen a website for a company called GenSpec, but they were marketing a set of nutraceuticals, and they had a website that had different colored bottles for African American men, African American women, Latinas, Latinos, white men, white women. And on the website would be a different color bottle for each group, and then you could click on your group's tab. As far as I could tell, it wasn't even clear to me that these nutraceuticals were formulated any differently. But the whole kind of publicity around it was that each sort of racial or ethnic group crossed with gender had a sort of uniform set of dietary needs within that group and a different set of dietary needs from other groups. So I think that out there in the public, there really is a confusion between personalized medicine and race-based medicine that we need to be paying attention to. And then I guess the final thing I would say is to reemphasize something that Michelle just said, which is that personalized is not just genetic. So, and I have a concern that in a practice context where providers are seeing people on 7.5-minute medical visits, that there might be this idea that we can substitute knowledge about someone's genome for knowledge about their family situations, their diet, their other medications. All of that is part of personalized medicine. All of that is what we need to know about an individual to deliver good health care to him or her. Knowing about the genome doesn't substitute for all of that other information that we need about people, but I fear that there could be an inclination to substitute very sort of quickly, easily, well, not easily interpretable, but at some point in the future, some aspects of it may be easily interpretable. And to think of that, we could just substitute that for actually delivering personalized medicine, which is personalized in all of its aspects.
Thanks. Dan?
Well, thank you, Robert. I think my talk will get most personal of all because I'm going to talk about aging. And as I look out, I see a few baby boomers in the audience, and they're becoming increasingly interested in this subject. 20 years ago, I was somewhat in an analogous position to Dr. Hughes. I was working in the United States Senate for a senator that was very active in healthcare. And one of the insights of a number of members of Congress at that time was they could see where the demographic trends were heading, and they were already aware that the aging of the population at that time in the mid-1980s, and especially how it would accelerate with the coming of age of the baby boom generation, was going to pose a challenge beyond imagination especially in the area of healthcare, with the federal government having made the commitments that it has made to subsidizing or paying for much of the healthcare of people. And they also realized that understanding aging, geriatric medicine, gerontological studies, understanding the relationship between aging and health was an academic backwater in the mid-1980s. And of the 11 institutes of health at that time, the Aging Institute had the dubious distinction of being number 10 in terms of priority. It's true the Dental Research Institute had somewhat lower budget line, but aging, the one condition that everyone is going to experience unless something a lot worse happens to them, was pretty much near the bottom of the totem pole. So out of that came the idea of an advocacy organization based in the private sector that could track the science, could talk to the news media, and come back to the Hill with a set of recommendations and some momentum around it for making scientific and medical research in aging and age-related health and age-related diseases a higher priority, and also, by the way, promote more training in geriatric medicine. And at HRSA, which had one of the few outposts where they were doing some training in geriatrics, that was slashed a year ago. So we're heading actually in the wrong direction. Out of about 700,000 physicians in the United States, we have a grand total of about 6,000 out of 700,000 that have additional qualifications in geriatric medicine, and the number is headed down. It was up about 9,000 a few years ago, but people are retiring, they're not going into the field. Now we're only 5 years away from the leading edge of the enormous baby boom generation, moving on to Medicare, moving past age 65 with all that is associated with that. And in the decade between 50 and 60, your chances of first being diagnosed with hypertension, type 2 diabetes, or arthritis will triple. And so by 65, you're starting to be at risk to all of the diseases that really are what is driving health costs in this country and really in other countries as well. It's chronic disease. Chronic disease accounts for about 90% of all of hospitalization, all medications in this country. And we are heading, with the aging of the baby boom generation, what we call the silver tsunami. We're going to see a tripling, perhaps a quadrupling, in the next 30 years of the impact of cardiovascular disease, cancer, dementia, vision loss, hearing loss. And frankly, we are not prepared for it. We are not prepared for it in terms of research or training or putting the resources behind it. And so that's sort of our organizational message. And when it comes to personalized medicine, I will join with those others who have said there's a lot more to aging than just a handful of genes. There's a 40-year discrepancy in life expectancy between the longest-lived subgroup in the United States, which happens to be Asian American women living in New Jersey, and Native American men in South Dakota. 40-year difference. Now that's not mostly, that's not just genes. There's a lot going on there. It's lifestyle, it's income, it's behavior, it's environment. And so aging is much more complex than just aging. However, personalized medicine does have the promise, the hope, of doing two things that are very important for people as they get older. Number one, perhaps learn the mechanisms to be able to delay the onset of those high risk factors or meet them with medications that offset those risk factors. And it's been shown that if you could delay the onset of dementia, for instance, by 5 years, you could cut it in half. Imagine the boon to families in this country if you could have that kind of impact. And secondly, to reduce the impact of side effects, of drug-related errors, which, again, it's been cited 2 to 4 million episodes, over 100,000 deaths. Indeed, drug-related errors would be the 5th leading cause of death in the United States if it were counted that way. And who are the people we're talking about? It's the elderly. It's the average 75-year-old who's on an average has an average of 3 chronic illnesses and on 5 prescription medications. That's the population that could benefit if personalized medicine and genomics would help us sort out the side effects.
Panel, you've just clarified something for me, and I think maybe helped us sharpen the language a little bit. And you said it, if I went to any doctor, any doctor in this room and any doctor in the country, and asked, do you practice personalized medicine? You'd say, well, yeah, of course I do. I know as much as I can about every patient, subject, as you said, to the 7.5-minute office visit. So personalized medicine is not a problem for the medical profession, for practicing doctors and practicing nurses. They're doing it. I'll come back. There's some gap, and I'm going to ask you, well, what do we need to teach them to improve their practice? Because I'm not saying we've got perfect medicine. On the other hand, the medical technology industry has dined out, has given fantastic stock returns, has been tremendously successful on unpersonalized medicine, on mass medicine, on medications that apply to millions. And what we're saying now is, gee, that's not good enough either. And so my first question to you, panel, is what do we need to teach physicians so that they can practice better? Not necessarily more personalized, but practice better given the advances in medical technology and the ability, finally, perhaps, to avoid medications that cause terrible damage and only give people medications that benefit them. Amalia?
Well, first of all, I'm going to play devil's advocate just briefly and slightly, and to say that I don't think it's completely true that physicians currently practice personalized medicine. I think they would like to practice personalized medicine. I think they believe that that's what they try to do, meaning in the physician-patient encounter, they are very, they try very hard to get to know the person in front of them. But there's several things that hamper that, and it's not just the 7-minute encounter. It's also the fact that standard of care is based upon what? Clinical results from clinical trials or results from large epidemiological observational studies like the Framingham Heart Study. So tell me how, but if you think about the patient from Laredo, Texas, okay, how is the Framingham Heart Study applicable to her? The Framingham Heart Study in Framingham, Massachusetts, with largely Caucasian men, okay, or Caucasian men and women. How is this Latina patient from Laredo, Texas, how is that Framingham Heart Study applicable to her? So I think what we need to realize is that the standard of care, and this is just one, trying to give you a graphic example, but the standard of care is based upon the statistically average patient, which is really mythical. It doesn't really exist. When patients, and for that matter, when physicians are trying to help patients make decisions for themselves based upon treatment decisions, what do they say? Well, the risks are 1%, whatever, 2%, based on what? Clinical trials or on these large observational studies. What does that actually mean to the patient? So if we realize that, then we'll understand that we really aren't practicing personalized medicine, regardless of whether we would like to be. So I think that's a key point to make.
So what we need to do differently and teach physicians is?
I think we need to start, well, first of all, we need more research on how do we help people make decisions based upon, in a very imperfect world, under conditions of really severe uncertainty. In other words, we need to find better tools that go far beyond probabilities and statistics, which is what we currently use. We also need to teach physicians a lot better, how to really understand a lot better what evidence-based medicine actually means, and how it sometimes isn't always very applicable to the patient in front of them. Sometimes it is, sometimes it's not. And we also need to move forward with the various educational interventions that we're talking about, and we can get more into that.
Michelle?
I think we need at least a two-pronged process, and I think paradigms need to shift dramatically in how we do research. And it gets back to what I talked about, participatory research. I think research cannot remain in an academic setting nor in a company by itself. I think that those companies or academic centers need to engage large communities, which I think they've begun to do, but I think they also need to engage a primary care community. And on the converse side, the primary care community needs to be a part of that. I don't think you can have the long-term health outcome studies, the kind of research that you need, unless you engage both of those entities in a real participatory way. And then the other process that I think that needs to happen, similar to, it sounds like what's been going on in Mexico, is that our national institute, our federal government, really needs to bite the bullet and have the kind of educational engagement of communities that it thus far has not had. It's largely focused on research and not using the money to really educate the public broadly, including healthcare providers, about the real implications, real understanding of genetics.
Pilar?
Well, I think there are a couple of things. One is the group of practitioners who know very little about genetics has been fairly resistant to change, say, through the decade of the 1990s. So the data that I've seen suggests that in the early 1990s, when you did studies looking at how physicians return genetic information to patients in a clinical context, that some 30% or a little bit more than that made some pretty serious mistakes. I saw later studies at the end of the 1990s that suggested was about a similar percent. I am all in favor of the CME, physician education and genetics kinds of activities. But I also think that as pharmacogenomics and other kinds of genetic testing become more a part of clinical care, and as they move from research into product development, we also really need to think about how to design these things as products so that the kinds of information that they generate and the kinds of information that go to the physician require less interpretation and are less susceptible to mistake by both the physician and the patient. I also think that we have we still have a large group of practicing physicians who went through medical school when there was so much less known about genetics. Some of this problem will diminish as we get more and more cohorts of physicians who have gone through medical school in the era of teaching molecular genetics. But it's not all going to go away, and it's not all going to go away with respect to patients.
So yeah, that's interesting. So that rather than requiring that every doc understand everything about P450 or copy number or anything,
Exactly.
Was it green or was it red?
Yeah.
And that's more manageable medical education task. Yeah, that makes sense. Dan, anything to add regarding physicians?
Well, I said earlier that I think the big disconnect in American healthcare is that you've got 13% of the population is over 65, but they're 50% of the patient population, and about 1% of the physician population has ever taken a course in geriatric medicine. That's the huge disconnect, and the same goes for nursing and pharmacy and all of the other allied health professions. But it's certainly true that you're going to have some emphasis on training physicians in the new personalized medicine. Otherwise, the advances that will come from science are not going to be delivered to the patient. But actually, I think you're going to have less of a difficulty in getting physicians to be early adopters of this technology because they like technology, they like new things. It's only been, 7 years since the genome, 10 years since BRCA1. We're still in the early stages of all of this. I don't worry so much about physicians wanting to know if there's a test that will know that their patient has a much higher likelihood of benefiting from a particular drug than others. I think technology is sexy, old people aren't. And so I think that's the problem, is getting them past the inhibitions they have on coming up to speed in a little bit of how to diagnose, how to manage, and how to treat older patients, because they're very different physiologically.
Yeah. I think there is technology to make old people sexy, but that's something else. I'd like to move to talk about individuals, talk about patients and consumers and citizens. I'm not sure quite what word to use, because I think that the line of thinking needs to extend beyond people who are in an active medical relationship around a clinical condition with a physician or other healthcare professional. I think my question really has to do with well, what do people want in this area, and how do we need to educate them so that they can know better what they ought to want? My sense is that we're, in some ways, we're moving to an era of personalized medicine, in the sense that we're shifting more cost onto individuals. That there's an era of individual responsibility, or maybe abdication of responsibility by some employers that previously did take responsibility for healthcare. However it comes about, people are increasingly going to be paying for their own healthcare. They're going to be caring about it, making decisions about it. Amalia, I know you're doing research in individual preferences in this area. Could you talk a little bit about that, and what at least your early conclusions are about what people want in this field?
Sure. Well, what we're doing is we've developed a survey instrument based upon a technique called conjoint analysis. And this is basically a statistically rigorous technique that is used to measure trade-offs that people make. It comes out of the economic literature, has been increasingly used in healthcare, various health economics. But we're using it, we're the first to use it really, to look at the preferences and decision-making surrounding personalized medicine applications. And the way it works is simply this. You present patients with research subjects with a scenario, a hypothetical scenario, but a realistic scenario. You know, you can use, for example, the off-sided breast cancer and Herceptin, or UGT1A1 testing for irinotecan and colorectal cancer, whichever. But we have several scenarios. And then what you do is you provide them with bundles of attributes, or features, if you will, characteristics regarding tests. So things like test accuracy versus privacy and confidentiality, versus test specificity, a whole cost. You can say, okay, well, the test will only cost you, on the one side, the test will only cost you an extra $100 out of pocket. The test will actually cost you $1,000. The test you only do a $30 copay, that sort of thing. So we have all these attributes, and then it makes use of what's called a forced choice set. So you have a set of bundles on side A and a set of bundles on side B, and for each of those attributes, or those bundles of attributes, they have to choose between A and B. And so that allows us to rank or rate preferences, and to be able to provide feedback, both for future policy, in order to inform policy in the future, but also for the people themselves as to what they're telling us, and how do we, in other words, we are able to measure how they trade off between all of those things. And our preliminary results suggest that cost is one of the #1 reasons that people are concerned about when they think about the possibility of using genetic information for making prescribing decisions. So basically, when they think about the possibility of getting offered a test, a genomic diagnostic test, in order for a physician to prescribe for them to have a prescription written out, the cost is one of the main concerns. That is followed by test specificity or test accuracy, and then followed by privacy and confidentiality. So, initially a lot of people would think, oh, privacy, confidentiality, will the insurance company have access to my results, that sort of thing, that's going to be a huge issue. But in fact, it's actually a little bit further down the line. So that's just a brief overview.
Let me ask you, as you've thought about it, what is it that we need to tell consumers so that they are better informed consumers of more personalized medicine. Michelle?
Well, actually, I'd like to comment on what I understood Amalia to say also, is that one of the first decision points was whether that physician was prescribing that test. And I think that actually is I think personalized medicine or some visions of it are shifting away from that scenario, because I think that is the clinical setting, at least the aging population is comfortable with, is a decision between their healthcare professional and themselves, and probably sometimes more weighing towards what the healthcare professional recommends. That's where the decision begins, whether or not to engage in personalized medicine or genetics. It's what's being recommended in that clinical setting. It's not necessarily a decision they're making on their own, which is what I think you're asking. And from then, different issues become more important or less important. So I think it goes back to, again, to that relationship and the understanding. So I think it's very important what that healthcare professional understands for the success or failure of genetics being incorporated into medicine. And when I, in my federal hat, funded a lot of projects, educational projects for primary care physicians and nurses. And actually, when one of my first projects, these were leaders of STFM, family medicine, the internal medicine equivalent, and the Academy of Pediatrics equivalent. And they were all, this was 7 years ago, and I was brought in this huge thing of genetic curriculum, and they said, well, what is this? We've never seen this before. It was totally foreign to them. And it gets back to something Pilar said in terms of what a consumer needs to understand. I said, well, you don't really need to know genetics. I said, just remember the family history, that's where it begins. Think genetically. Think, when is genetics important? And that is what became, what was important to them. And I think that's one universal aspect of family history, both for healthcare professionals and consumers, or the public at large, is looking at your family history, looking at your family stories. When is genetics important? What's running in the family? And I think that's what begins to resonate, and I think that's a story you can go forward with.
Yeah, this is key. So when is genetics important? When should you be triggered to contemplate one of these tests, rather than necessarily doing it automatically and kind of coming to what Pilar was fearing of, sort of this substitution of the all singing, all dancing diagnostic genetic test for clinical judgment. But what we're saying is, let's add to clinical judgment when it makes sense to get a genetic test. Pilar, you're going to add something.
I guess I was just going to go on a slightly different tack and say that one thing we don't yet know is, who our patients are going to be in terms of their understanding and integration of genetics into their lives in other ways. So whether it's nutraceuticals that are being sold purportedly as sort of a genetically based intervention, or whether it's people who do genealogies. I am told that the second most frequently visited type of website after pornography is genealogy websites. And to the extent that people are using molecular genetics in their genealogy more and more, that is something that they're going to be bringing to the clinical encounter too. And even things like cosmetics being sold to people as sort of the genetically targeted, personalized cosmetic for use. All of that is going to come in the clinical encounter too. So we shouldn't forget that people are interacting with, they're learning about themselves and about genetics through a lot of different routes besides the medical, clinical, doctor-patient relationship. And I really don't know yet, where that's going to go or what impact it will have, but I wouldn't be surprised if it had some effect.
I think that's a very, very important point, and the information that they get may not have been through quite as rigorous a filtering process as the randomized clinical trial. However, they're going to show up with that information, and just as the clinician has to be ready for patients who show up having been affected by direct-to-consumer advertising about pharmaceuticals, they need to be ready for that. Dan?
First of all, I always thought that after pornography it was healthcare. It was health and medicine, so you've set me straight. It's genealogy. But we know that something's in second place. I think it's important to understand there is a generational divide that's now taking place. The World War II generation, the Depression-era generation, it was doctor knows best. They were very passive. They accepted and anticipated that they were going to be sick and disabled, and they accept that. The baby boom generation, very different. Many of them are, not all of them. It's hard to generalize about 77 million Americans, but we do know that they are. Many of them are disciplined consumers. They understand the benefit of shopping around. They have, many of them, used to going to the internet, getting information, and we know that that's not all reliable information. I think when it comes to personalized medicine, it's going to be like other health information that's out there. There is an organization, which I will not name because they like to throw around lawsuits, but they hand out degrees in anti-aging practice to a lot of physicians. And I heard a frightening statistic that there are more members of that, doctors that have signed up for that than the American Geriatric Society. So doctors realize their patients are coming to them. They want to know about nutraceuticals. They want to know about homeopathic medicine. And physicians are feeling like they need to be able to give them something back. So I suspect the personalized medicine will evolve probably in the same way. There will be early adopters, and a lot of physicians will want to know about it.
Audience, let me take it to you for any questions or comments that you might have. We've got time just for a few. Yes, right back there in the back. Is there a mic running? There it is. Could you put your hand up again, please, right there? Yeah. You see it?
I'm just a little perplexed and perhaps troubled by the idea that I came to this because I got an email, and it said the genetic age, the era of personalized medicine, and it took me a while to kind of figure out what I thought that meant, because I had never heard such a term. I'm not a physician. And I took it to mean that personalized medicine had everything to do with what somebody was going to tell me about my own genome. And put that together. And as I listened this morning, I guess I became more disconcerted that was indeed what it sounded like personalized medicine was. And I wonder if the physicians in the group aren't perhaps, I think I'd be a little offended by this term being used, because as a patient of many, many physicians, I've also never encountered a clinical encounter that I didn't feel was personalized. And it seems to me like genomics has co-opted this concept, and I think that it's troublesome from a public point of view, because it makes it sound like medical practice is simply figuring you out as a genome. And in fact, the panels before, pretty much, if you analyze their conversation, sounded like person equal genome. You know, that their bench science vision or perspective was just that. And it also concerns me for the viability of the profession of medicine. If you have to compete with people like me or physical therapists for whom genetics is important, but our goals have to do with people doing things that are really clear to them, in terms of somebody has a CVA, and you're going to deal with their vascular issues on a pathological level, but the therapist is the person who gets them up and going. It makes it seem like we're even more intricate or personalized in their care. And I think those are all really big issues that need to be fleshed out, and especially if, you know, this new bill comes out and you're looking at funding research, I think a lot of that funding has to go to those more qualitative questions.
Yes, I don't think I heard a question in that, but if there's a comment that any of you would like to make in response to that, I guess I would just say that some of what we're about here is trying to tease those apart and to go very much in the direction of not trying to munge together or make personalized equal genetic. I think that's a dangerous path, and I thank you for pointing it out.
I'm just going to say something very briefly. First of all, thank you for your comment. I think it's important for us to hear your perspective. So I appreciate your comments. But I also think it's important for us to keep in mind, and I think to some extent we're all saying that here, that the genomics piece of personalized medicine, so whether we're talking about pharmacogenomics or other genomic approaches, is really going to work most effectively when we realize that it has to work in conjunction with other aspects of how medicine currently works, and that includes family and clinical histories. It includes, clinical judgment in the usual physician-patient encounter, so that it isn't something that ought to take over. And this is the new paradigm, and we're only going to practice personalized medicine by taking a blood sample from you and running that through and telling you what that test means and how we're going to prescribe medication for you or what treatment you need, but rather just, this is, in this particular instance, perhaps to help you avoid an adverse drug reaction or, get a better safety profile or a better, more effective drug for you. This is where we might use it in this case, but perhaps not in another case. And so I think it's important to keep that point in mind.
Can I say something?
Yes, go ahead. Mike, could you bring the mic down right here? Could you hold your hand up so you can hear it?
When I began, I told you I went out to 20 pediatricians. Almost all of them, the majority of them, I think 15 out of the 20, were actually very offended. They thought they were already delivering personalized medicine. So there is a problem with the message that I think it needs to be recrafted of what it is you're talking about with the incorporation of genetics into medicine. And so I think that needs to be heard.
Thank you. Yeah.
Yeah. So I think the term it may just be some semantics, but when I read it or when I use it, I'm talking about personalized genetic medicine, not necessarily personalized medicine. And I think it was sort of split unnecessarily early on. But the point I wanted to make about this panel, which I think is great, is you talk about individuals, and who are these individuals? This is, once again, another sort of big science venture, sort of leveraging on what we know about DNA variation from sequencing, what we know from HapMap, and now what we're gaining information and knowledge from these big, large-scale genome-wide association studies. However, we're still sort of operating in the framework of studying the average white male, pretty much. And so when we talk about individuals in a society that is very diverse and is extremely heterogeneous, it scares me some when I think about what the ultimate outcome of this is going to be. Now, I'll use, for example, I like to give examples. Let me give you one other example. There is a reason why Native Americans and Hispanics were not in HapMap. I mean, part of it is because it was an engagement issue. There was no it was difficult to engage them, and that's why I'm really excited, and I applaud the Mexican government for setting up their own genome center and genome project. I think we have to understand that in order for us to be very successful with our repositories and our biobanks and our research projects, we have to be very effective and get off of these sort of these not Eiffel Towers, but these ivory towers of talking to the community. I mean, we have to engage them in a fashion that they can understand and get excited about this and buy into it. And so I just want to know what the panelists think about this whole issue of this individual and who, the aspect of engaging different communities. How do you see that as something that's going to be problematic, or is that going to be something that could be resolved and for personalized medicine.
Thanks.
Well,
Michelle?
it is problematic. We have history that's problematic, but I think it's absolutely necessary for medicine to be personalized. Otherwise, you are leaving large segments of our society out. So I agree that it has to be done. How we do it, we haven't been very successful in the past. And we have core issues in this country that getting over that history, I think, is going to take a lot of long, hard work. But I think this is an opportunity to move past some of that. But it has to be some real commitment on the part of researchers. I think the federal government, again, I think it has some obligation here to finance the kind of education that we need. But I'm a little cynical.
I mean, I think obviously it's a huge problem. And part of it is a workforce issue. Part of it is who works at NIH, who are most of the molecular geneticists and most of the major research institutions in this country comes from a pretty narrow slice, racially, ethnically, class-wise. And so who do they even know to engage, right? I mean, there's a real startup cost there in the sense of just getting to know people, developing long-term relationships, which is clearly very important. And I think there also are a lot of issues about who exactly should be doing it. So one of the problems we've had is if the researchers are trying to do it for each major research project that they're involved in, to some extent, they don't have the knowledge or the skills to do engagements in many cases. And there's no long-term connection into communities. So perhaps it's better for institutions, whether it's a university, whether it's NIH, to be putting a lot of that effort into developing long-term relationships deeply in communities. I also do think that there are efforts, right? There are efforts going on. There are efforts going on to do more sequencing in different African countries and communities in Africa. MalariaGen is working on a big sequencing project to look at susceptibility to malaria. They're small, they're tentative, they're starting. I would also say, though, that it's not, in terms of trust, and specifically with Native Americans, it's not only about the past history, right? University of Arizona has been involved in a lawsuit for almost 3 years now with a small tribe in Arizona. This has now, and I should, as a matter of full disclosure, say that I'm advising the tribe in this matter, has to do with research that was done on the tribe's tissues. Tribes from all over the country have gotten involved in this, have gotten involved in funding the lawsuit, have gotten involved in actually withdrawing from clinical trials that they were committed to doing with ASU researchers. It's not only about the history, right? So one of the things is research institutions being very careful to behave in a trustworthy manner. And this is one of the reasons why this whole question of doing genetic research with stored tissues is such a difficult one, because on the one hand, I think the notion of the kind of informed consent that developed as a kind of informed consent for invasive, direct kind of research on a person may not be the kind of informed consent that's going to just work very well in the era of very large-scale, longitudinal kind of studies, or studies where we're trading around samples and sharing them.
We've got time just for one more question right here.
I'll do my best to phrase a comment in the form of a question. The prior
if you want to make a comment, that's fine too. And
the prior questioner, I think, touched on this, and I've in our institution, I've worked at how do you educate health professionals. But if in the coming era of personalized medicine, if a pharmacist, for instance, can do just as good a job at picking a medication for my hypertension, picking the dose, and informing the patient of the side effects, what does the panel see as the fundamental shift in what it is that health professionals do in this new era of personalized medicine?
Can you redefine the boundaries of practice given the kind of genetic information, or expand them? Yes.
I think this is a generational issue. My 20-year-old would love to have medicine that way. He doesn't have time. He'd like to go to his computer and look things up. So, I mean, I think there are some generational issues. And I think there is a possibility, the one member of the previous panel sort of alluded to this, that things, some aspects of medicine may go out of the clinical setting. But I think there's a transition point there.
Dan?
I have to agree with the question that I think we make have a tendency to make too much that personalized medicine is so new, so different, so arriving here from outer space that it's going to not be able to fit in. We have a healthcare system that's already broken 6 ways from Sunday. We know that there is health disparity issues across racial and ethnic groups and income groups and even by age. That's another person you won't find in a clinical trial is anyone over the age of 50. And yet, who are the people using the medicines? But there's a lot of things that are broke. But there's no inherent reason why a physician or a pharmacist, if they have the information of what the medication is, who it's appropriate for, that's going to come from the doctor, and what the dose is, there's no reason why that's going to be fundamentally different. If we have the medications aligned with the test, which aligns with the patient for what is known about a particular genetic indication, but that's not going to be the whole picture of how to get that person well again. If we put that in the right perspective, the big question, I think, is whether we're going to have the information coming out of research that tells the physician what drug, what dose for what subpopulation. That's where the potential blockage is, and it could be a blockage that's exacerbated by concerns about privacy, confidentiality, costs, and all the rest.
Panel, we're down to just our last couple of minutes, so I'm going to ask you the same question that I've asked each of the other panels. You probably anticipated this one, and it's the question thinking 5 years out in December of 2011. Because our time is short, rather than asking you to give the essay, I just want the headline. It might be a headline in the New York Times. It might be a headline in the Journal of the American Medical Association. I don't know what, but just the headline of the most important story of December 4th, 2011, regarding this area.
Paradigm shifts in regulation, legislation, and in the drug development process, meaning the way clinical trials are done.
That's the New York Times. No other newspaper uses paradigm in a headline.
That's right.
3 million citizens in the United States and Mexico are working with their institutes of health to participate in genomic research.
That's the hopeful one.
That's collaboration across the country.
Pilar?
I'm not going to give a headline. I'm going to say that what I would love to see is if we had a bit of a shift in research governance so that we had a better ability to ensure that information coming from the communities that are being engaged actually got also to the lab bench, because that would inform the research and ultimately the medicine. And if that's a kind of research governance issue, not necessary to take care of it with regulation, but
That's a headline from a law review article, I think.
I can guarantee you that January 1, 2011, the front page story is the first American baby boomer turns 65 and joins Medicare, and 9,999 others did on the same day. Because we will be going from 6,000 a day turning 65 to 10,000 a day in 2011, and it's going to stay like that for 18 years. That's the age wave. That's the silver tsunami. But the subhead is bioinformatics, which is the larger picture in which personalized medicine is part, will have dramatically improved research, clinical trials, drug development, and we will have a whole new armamentarium. That's what will benefit first from personalized medicine and bioinformatics. It's not going to have that big of an impact on doctor-patient relationships.
Yes. Wonderful. Panel, thank you very much, and thank all of the panels. And I would like to thank all of you as well for your attention and your active participation. Thank you so much. And I'll add my thanks also to Affymetrix and to the Genetic Center here at Northwestern University for hosting us. Thank you.
No, I'd like to get yours too.